In this next section entitled Diabetes Medications, we'll discuss insulin and other medications commonly given to patients with diabetes mellitus. In this section, we'll discuss diabetes medications. Insulin is an anabolic hormone. That means that it promotes growth. That's important in the metabolism of carbohydrates, amino acids, and fatty acids, not only carbohydrates. Patients that have diabetes can either have type 1 or type 2 diabetes. Type 1 diabetes, as you know, involves the pancreatic islets producing little or no insulin. Patients that have type 2 diabetes generally have lack of sensitivity of insulin. They can often have high levels of insulin, but they sometimes require insulin therapy in order to keep their blood sugar at a low level. Some patients that have type 2 diabetes may be very young. This non-conventional type 2 diabetes is actually increasing in frequency. It accounts for less than 1% of patients that have type 2 diabetes. This can occur in patients that have defects in the molecules glucokinase, the insulin molecule itself, the insulin receptor, or the glucose transporter GLUT4. Metabolic syndrome is another topic that seems to come up a lot in clinic. Metabolic syndrome is defined by the American Heart Association by the following criteria. Men that have an elevated waist circumference greater than 40 inches, women that have with a waist circumference greater than 35 inches, elevated triglycerides, reduced HDL, elevated blood pressure, and elevated fasting glucose. Patients with these findings generally are considered higher risk for adverse cardiac events. With regard to diabetic management, the cornerstone of therapy is diet modification and exercise routines. Patients that are able to keep their diet healthy and exercise daily, if they're type 2 diabetics, will generally not need insulin. Type 1 diabetics will always eventually require insulin replacement. However, because type 2 diabetes is associated with obesity and poor health habits, if those patients are able to modify their lifestyle, sometimes they will not need oral hypoglycemics or insulin. In terms of monitoring diabetic patients, the plasma glucose measurement again is a snapshot or a single time point in glucose control. However, the hemoglobin A1C gives the measure of glucose control over a several month period, the life of an erythrocyte. Remember, erythrocytes can live for 120 days in the peripheral blood. The current data from the American Dietetic Association recommends relatively tight control over this number. An A1C of 7% is considered to be the target for all diabetics. This equates to an average blood glucose over the day of 150 milligrams per deciliter over a few months. When patients are receiving insulin for diabetes, there are many different preparations and types of insulin that are given to patients. The most short-acting insulins are the insulin aspart and the trade name Novolog. These medications are injected and are the fastest onset and shortest duration in terms of insulin preparations. These are given 15-20 minutes before meals and become active during the meal. They help the patient digest the meal that they eat. Regular insulin is a little bit longer acting than Lispro. It works within 30 minutes and is active about 5 to 8 hours. The intermediate acting insulins, including isophane, Lenti, NPH, zinc suspension insulins, they start working about 1 to 3 hours after injection and are active almost the entire day. The longer-acting insulins, such as insulin glargine, also known as Lantus, work for a long time and are usually dosed once or twice per day. These medications will start working within 1 to 2 hours after administration, and they'll be active for about 24 hours. These medications are meant to represent the basal amount of insulin that the body makes, even when it's not eating food. Here are some examples of different types of insulin regimens that patients can be on. On the top, you see the most simple type of insulin regimen. This patient, as you can see, takes 2 doses of insulin every day. And this patient is taking 70-30. What that 70-30 refers to is that 30% of the dose is a regular insulin and 70% is NPH. That NPH, or intermediate acting insulin, will last a long time and serve as their basal insulin level, whereas the regular insulin will be active from breakfast until lunch, and then the patient will receive another dose of the 70-30, and as the original dose of NPH wears off, their new dose of NPH will take over and last as a basal insulin throughout the night. This regular insulin will help them throughout supper. This is the most simple because these patients only have to take insulin twice per day. Other insulin regimens are more complicated. For example, we have this patient here on the bottom left that's taking Lispro or short-acting insulin with every meal, breakfast, lunch, and dinner. This patient also takes, in the morning, NPH or Lenti insulin, and then right before that patient goes to sleep, they take another dose of NPH or Lenti insulin. On the bottom right, you can see the same pattern, except the patient is taking regular insulin with each meal and using ultra-Lenti or very long-acting insulin instead of Lenti insulin. The point of insulin regimens are to maintain both a basal and peak insulin in order to help the patient digest their meals as well as maintain a basal insulin level all day long. There's some important concepts to remember for type 1 insulin, or for type 1 diabetes and insulin regimens. The Somogyi effect is seen in a patient that has a long-acting insulin and is developing a low blood sugar around 2 to 3 a.m. while they're asleep. If a patient has a low blood sugar, the body will respond by releasing cortisol, epinephrine, glucagon, and growth hormone, which causes the patient's blood sugar to be very high by dawn. The patient will see that very high blood sugar and increase their insulin dose. The problem is that that increased insulin dose will just worsen the hypoglycemia that occurs at 2 to 3 a.m. the next day. So this is often a self-repeating cycle. The way you can prevent this is either by measuring blood sugars at 2 to 3 a.m. You set an alarm for yourself, or you can give the patient a bedtime snack that will help them not have a low blood sugar at 2 to 3 a.m. Dawn phenomenon is something different than the Somogyi phenomenon. Dawn phenomenon occurs in everyone. This is a situation where counter-regulatory hormones are often peaking around dawn, and these would be like cortisol, glucagon. And this counter-regulatory hormones can actually cause high blood sugars in the morning. This can be minimized in diabetics by the use of long-acting insulins that cause steady levels of insulin to be introduced into the body. For example, long-acting insulins such as glargines, or by using insulin pumps, which continuously pump insulin into the subject. Insulin pumps are very powerful tools in the treatment of type 1 diabetes. The way they work is they provide continuous subcutaneous insulin infusion, and they're very good for patients that are not good at taking their insulin. It uses regular insulin. Islet cell transplantation is a experimental procedure that is currently under investigation. There are no current standard of care islet cell transplantation centers, but though there are some type 1 diabetics that have been cured through islet cell transplantation. Although insulin helps lower blood sugars, it can actually cause overdose. And the overdose of insulin can cause hypoglycemia, and this can result in tachycardia, sweating, and nausea. And severe overdose can actually cause unconsciousness, convulsions, tremor, and confusion. For treatment of insulin, obviously you'd want to give the patient sugar. You can give them IV dextrose solution, which contains glucose. And you can also give intramuscular glucagon. Both of these will elevate blood sugar. These patients will also need potassium and magnesium because insulin itself can lower blood potassium. Therefore, they most likely have a very low potassium level if they've overdosed on insulin. Let's talk about oral hypoglycemic agents. There are 4 major classes that we should talk about. The first class is sulfonylureas. Sulfonylureas work by stimulating insulin release from the pancreas. This insulin then goes on to break down sugar in the periphery. Sulfonylureas are good for controlling hyperglycemia in type 2 diabetics. The 2 major sulfonylureas that are used today are glyburide and glipizide. Adverse effects from sulfonylureas are very important to remember. Sulfonylureas can cause hypoglycemia more than any of the other oral hypoglycemic agents. High doses of these medications can lead to excessive insulin release, and insulin release can cause hypoglycemia in all patients. These can also cause weight gain and hypersensitivity. These have sulfonamide groups. The next classification of medications that we'll talk about today for diabetes is the thiazolidinediones. Some of the popular medications in this category include pioglitazone and rosiglitazone. These medications enhance the uptake of fatty acids and glucose into adipose tissue, muscle, and liver cells. These do not cause hypoglycemia as much as the sulfonylureas. As you may be aware, there are some controversy regarding thiazolidinediones, especially rosiglitazone, also known as Avandia in the United States, and its role in cardiovascular risk. An initial study in June of 2007 showed that users of Avandia to be at higher risk for cardiovascular death, but later studies showed no difference between Avandia and metformin or glyburide. It's unclear whether Avandia causes an increased risk in cardiovascular death. Most likely, if it does, it's a very small risk-benefit ratio. These medications are very good at controlling sugars in diabetics, so they're often still prescribed today. There is an association with an increased risk of bone fractures in some women taking these medications, and these meds can also cause increased weight gain and edema as well. Metformin or glucophage is usually the first oral hypoglycemic medication that's given to type 2 diabetic patients. This medication increases glucose uptake and decreases glucose production in the liver. It does not usually cause hypoglycemia. This one does not promote weight gain. Usually it actually promotes weight loss. There are some important adverse effects to metformin. It can cause an idiopathic lactic acidosis that is often precipitated by a radiologic study. Metformin should be held for 48 hours after and before the administration of intravenous contrast media for a CAT scan or for some other radiologic study. Metformin is also contraindicated in patients that have renal disease, hepatic disease, past history of lactic acidosis, or hypoxic respiratory disease. Acarbose, which is a less commonly used oral hypoglycemic, works by slowing the absorption of carbohydrates in the intestines. It's very safe, however, it does cause a lot of annoying side effects, including bloating, diarrhea, and flatulence, because bacteria then are able to consume the carbohydrates that stay in the colon and cause gas production. This is the end of our diabetes medications section. In the next section, we'll discuss medications commonly given to patients with thyroid conditions, both hyper and hypothyroid.